Hi, good afternoon. We're from Bempu Health. We're a social enterprise based out of Bangalore, and we make health interventions in the neonatal and maternal healthcare space. This is our first product. This is a hypothermia bracelet for newborn babies, which we've managed to deploy to various states in India and some countries with the help of Gates Foundation, USAID, and Saving Lives of Birth. And with UNICEF, we've reached Zimbabwe, Benin, and Papua New Guinea. So while we were working on our bracelet, we also identified various other needs, and so we have a portfolio of products. Today, we'll be focusing on the Care Cradle. So the Care Cradle is a hybrid product service, which it's a hybrid product service which monitors babies, high-risk babies at home after they get discharged from the neonatal ICU, and this is usually in low-resource settings. So just to give you some context, there are 750,000 newborns who die each year in India. Critical neonates, especially in low-resource settings, are discharged early from their facilities because of the lack of available beds. And the high-risk period is thus spent in uneducated and geographically isolated homes. So again, because the parents are not well aware, they are not usually taken to the facility if the parents are unable to identify symptoms that could indicate eventual sepsis, mortality, and other things. And so they develop illness at home, and this could lead to. So what we did was, through this cradle, we collect clinical data. This is through a smartphone, which is on top of the cradle. We collect videos 4 times a day. We ask the parents to record a 2.5-minute video with the press of a button 4 times a day. And we also have a vital sign monitor, which is placed on the baby, which collects the heart rate and the SpO2. And nurses call the parents for an audio account for information about feeding, stool, urine outputs, etc. And all of that information is collected on our dashboard to make a comprehensive assessment about the baby's health. So now we have a team of clinicians on the back end who review these symptoms for deterioration signs, and then they alert the family, or the health worker in the area is alerted. So this is how the system works. I'll talk to you about the data.
So using a prototype which looks like this, we've tried this program out. We've piloted it in Karnataka, in Shimoga district, in Telangana, and in Bangalore as well. So we have use cases from rural and urban India, and we've seen a lot of positive value. So we've tried this with about 100 babies, and in those 100 babies, we've detected five cases of readmission. So this includes readmission to tertiary care due to illnesses like jaundice, sepsis, respiratory distress, etc. And we've also, even illnesses that don't require readmission, but just a revisit to the facility, can be diagnosed through signs like skin color, a drop in the feeding pattern of the baby, any sign of dehydration, any sign of high respiratory rate or chest and drawing, etc. So we see that there is positive value, but it's difficult to scale this program because of certain challenges. So one major challenge is that we require skilled human resource. So currently the clinical team consists of nurses and neonatologists with significant experience in neonatal care. So the first round of assessment is done by nurses, and if there's something that is deemed to be wrong with the health of the baby, this is escalated to a neonatologist. So each packet of data would need at least 15 minutes from a nurse to be reviewed. So effectively, one nurse in a working shift could only see about 5 to 7 babies per day. And so there's the time taken to monitor this data, also time taken to collect the data in the form of audio counts, which is like speaking to parents, asking simple follow-up questions. There's also a lot of subjectivity. So as you might have seen in the previous slides, that's an example of the images that we receive through these videos. So through these videos, the nurses are expected to assess the skin color of the babies, the chest movement, and this could, this would depend on the skill level of the nurses itself, and also on ambient lighting, the way the video is shot, etc. So factors that could be controlled and require a reduction in subjectivity when it comes to analysis. So this is a vision of how we think technology could help us in scaling this intervention and reaching across to more babies. One would be risk assessment. So we think that we could make better use of the skilled workforce simply by doing a preliminary assessment, so such that the cases that require urgent attention reach the assessor first, and also flagging some severe danger signs which do not even require a clinical assessment but would simply require medical care. So this would reduce response times in such a system. Then there's also the workflow of, can you go back? Yeah. Then we can also improve on the workflow. So if a nurse sees that a baby is falling ill, typically we ask follow-up questions like what was the feeding pattern in the last 24 hours. So we try to collect information about the current medical behavior and also past history of the baby, which we think could be automated again to increase response times. And also, once we prescribe a line of treatment, there could be more effective ways of sending reminders and tracking if the treatment is being followed through technological systems. In terms of the video assessment, simply also we think that there could be data processing such that preliminary assessments can be done for respiratory rate, image analysis can be done to see skin color, reduce subjectivity, and shorten the time taken to review these 2.5-minute long videos. Yeah. So the data that we have right now so we start from the day of enrollment in the study, right? So we have a lot of baseline data. So we know factors about the baby's birth, like the weight at birth, the gestational age, how long the baby has spent time in a tertiary care facility, what kind of care did it receive at the tertiary facility. Then we also have demographic information about what was the age of this mother, is this the mother's first pregnancy, what kind of a household does the baby come from. Then in terms of the daily monitoring, we have videos. So we have detailed analysis from these skilled nurses about what was the activity level in the video, what was the baby crying, was the baby crying loud enough, was there any chest indrawing. Then through our vital signs monitor, we have data about the average heart rate in the 2.5-minute video and also the oxygen saturation. Then through the audio counts, we have details about in the last 6 to 8 hours, how often has the baby been fed, how often has the baby passed urine or stool. Does the mother see any abnormalities? Has she seen any convulsive movements? Has she seen anything on the skin of the baby that could potentially be problematic? Yep, so that's the end of our presentation, and we do have some ideas on how we could leverage the data, and yeah, we're excited to discuss it in the following sessions.
One questions. You said you're piloting this. How many babies has this technology been used with?
We've used it with a little over 100 babies in Karnataka state and Telangana state of India.
Hi, what device are you using currently for video monitoring? Are you using a mobile phone?
Yes. For our pilot projects, we're just using a smartphone because that enables us to control the quality of video that comes in, and also this packet of data can be sent through cellular network. So yeah, we're using a smartphone right now.
But won't mobile phones be contaminated most of the time? Because, I mean, there was a study I read a few days back about talking about how 101 out of 105 mobile phones that they studied was contaminated with bacteria in healthcare.
Okay, can you go back to the slide with the picture? So this is what the product looks like right now. So the smartphone is placed on top of the stand, which is at least 40 centimeter above the baby. So there's no point of time when the baby is in contact with the phone. I hope that answers your question.
Yeah, okay.
We take one more question, and then we'll have a breakout session to discuss this further.
I guess you guys are doing what sounds like a relatively small scale pilot right now, but just in terms of thinking about how you might want this to be implemented, who would you imagine actually buying and having this resource, and how do you imagine it would be used?
Okay. So you saw the product that we've developed before, which is the hypothermia bracelet. And so for that product, we have used government channels as well as private channels. So we see a system where we would integrate our clinical team with the tertiary level facilities in district hospitals, and we would be enrolling babies that are discharged from these facilities. So we expect that the government would work with us to subsidize the care that this system could offer to these babies being discharged from the hospital. And also in the private cases, even in tier 2 and tier 3 cities of India, so remote assessment would significantly reduce the cost and increase the quality of care that is accessible.
So, Milind, you had one question. We'll allow. Okay, we can take the.
I think in the interest of moving to the breakout, I'll hold it.
Fantastic. We'll come to you.
So you mentioned that there are audio accounts of players. So are these in local languages? Are these in local languages, or they are mixed, code mixed, or what kind of accounts are they?
They are largely in local languages because 60% of our use cases are currently in rural India, so they would be in local languages. Yeah.
So currently you get them transcribed by.
Not transcribed, but they would be assessed on the call. So we don't note down everything that is relayed by the parents, but we would only note down like the frequency of feeds. We'd convert that into as many quantitative values as possible.
Okay. And is that interactive?
Yeah, it's a phone call.
Okay, thank you.